Thank you, Mr. Chairman. Dear colleagues, I'd like to thank the organizer, GIS, for this invitation. And so starting with valve-in-valve, I would recommend this application that you can just obtain, which is a wonderful tool, especially for beginners and also for those who carry on. So these data from the Partner 2 registry show that, in fact, valve-in-valve is with sapien valve is giving a good result, and at 3 years you obtain a good gradient and a good persistent valve area. And the NYHA functional class is also very nice after 3 years. Similar data coming from the Viva core valve registry. These are the results at 1 year, showing a similar result, so which is something which was has to be shown. So here you can see different type of bioprosthesis with the core valve. This is from the publication of Didier Tchétché. And so let's go now to the meta-analysis. There will be 3 meta-analyses showing, in fact, that the 30 days mortality is absolutely reduced by 7.5%, comparing with the propensity score match analysis. The new pacemaker is decreased by 9.8% and blood transfusion by 63%. So another meta-analysis showing similar data, confirming the 30 days mortality reduction, 30 days morbidity reduction, and also decrease of the major bleeding compared to surgical redo. And the last one from Eurointervention, showing again better TAVI regarding redo surgery, considering the bleeding, the morbidity, and the mortality. It is important to mention, however, that valve-in-valve bioprosthesis, there is an increased leaflet thrombosis, there is an increased coronary obstruction risk, there is an increased residual gradient risk, and also there is an increase in structural valve degeneration risk, which was, by the way, maybe the mechanism of the previous very nice presentation, even if it was in the mitral. Regarding the mortality is higher than in the native, 5% at 30 days until 62% at 8 years. And though if we compare the type of valve-in-valve bioprosthesis implanted, it seems that the self-expanding is being better in terms of residual gradient, and there is decrease in terms of 8-year need for reintervention. So small bioprosthesis will be related to worse 8-year estimated survival. And so these more recent MASHRE meta-analysis showing that at 1 year the death is in fact equivalent between surgery and valve-in-valve TAVR. So interestingly, this meta-analysis specialized in low-risk patients, which is very important because we are now going to this population, young population. And in fact, at 1 year and 1 month and at 1 year, as we can see, there is this is in favor of TAVR. However, we will see that we have to discuss now the access to the coronary arteries. What is the long term? We have this paper from a TAM showing that in fact there is a non-significant difference in terms of mortality at 5 years between valve-in-valve and redo surgery, as well as this paper from De Haro at 4 years showing no significant difference, 18.6 versus 21.9 with a combined endpoint. So this is a valve-in-valve core valve follow-up at 5 years, showing a discrete decrease, in fact, in the in the area, but still significantly good results. So valve-in-valve thrombosis is definitely higher than with the native valve. The diagnosis is easy. Usually it is performed by echo and confirmed by a CT scan. And definitely the warfarin treatment is the good solution, but it can reoccur if you stop warfarin. So coronary occlusion by bioprosthesis, it's a severe but a rare complication to be evaluated a priori. And as you can see, it depends on how the valve is or the second valve is oriented regarding the native valve. So for the sake of time, I will go very fast, but we have to see first the coronary height between the annulus and the ostia. Second, we have to look at the VTC distance, which is a valve to coronary distance. And when this distance is less than 2 millimeters, then there will be some risk of no access secondary in terms of acute coronary syndrome with a valve-in-valve. So this is, I would say, a major problem if we consider that for the young population, valve-in-valve TAVR should be preferred to surgery, and I think this is something to be discussed. The participation mismatch is a major risk factor for mortality and failure, and this is something which has to be definitely mentioned, so this will be a good transition to discuss about cracking the valve based on the result of the final gradient, which should definitely not be beyond, I would say, between 15 and 20 millimeter mercury. So cracking the degenerated bioprosthesis, in case of mismatch in surgical bioprosthesis, mismatch after valve-in-valve, small bioprosthesis, I would say that the technique is amazingly viable. It's quite easy, and the risk-benefit is really ideal. It is not possible for all the bioprostheses. As you can see, the St. Jude trifecta, as well as the Medtronic Hancock 2, is problematic for cracking the valve. I would say that also it's very interesting to see, by the way, with this application, how do you locate your bioprosthesis in order to position correctly your TAVR. So the technique of cracking is based on the pressure with a non-compliant balloon, which will be able to definitely crack the annulus of the bioprosthesis. You have to go until 20, 22, 25 atmosphere until you see a sudden drop of the pressure in your inflator. You can also see this on the screen, and sometimes you can even listen to the noise, a brutal and quick noise. It is not very often, but don't wait for the noise. Here you can see on the A, B, C, D that on C you have been able to crack the valve, and then you can deploy, you can just withdraw your balloon and make measurements. Here with this reconstruction you can see the valve broken at the level of the annulus, and here it's even easier to be seen. The Carpentier-Edwards is cracked. And now the new Carpentier-Edwards are prepared to be cracked, which is interesting. So the technique of cracking, you see on A, you see the gradient, and B, the gradient is almost gone, and then when you retrieve the balloon, there is no more gradient, and you succeeded. It is 1-0. It is no, I did a little work. No, if you crack, you crack. You have to see that and to confirm that with the gradient. So the technique of cracking, avoid coronary artery too close from bioprosthesis. it's a good remark. So in conclusion, valvular valve is a tremendous tool to help degenerated surgical bioprosthesis, a mandatory technique with an infinite reserve of patients. Need to know the complication, and I would especially mention the coronary occlusion and the impossible access for the valve in the future. So we have to really be careful not to consider that now every degenerated bioprosthesis should get a TAVI. Thank you.